Catherine Connolly.
And I welcome the opportunity to speak on the Health Insurance Amendment Bill, which is an annual piece of legislation. And it's I want to thank the Department and indeed the Minister for the work. That will be the end of my positive praise, really, when I go into the background as to why this is necessary. It's a short bill, 10 pages and 7 sections, and we go through this every single year. And in fact, it's really important in what we've created here. This is a necessary mechanism to equalise the risk faced by different insurance companies. And the briefing paper has been very helpful. And just for anybody listening subsequently to this, I think it's important. It's been spelled out. The risk equalisation is a process that aims to equitably neutralise the differences in insurance costs that arise due to differences in the age profile and health status of their customers. So in the limited competition that we have with a small number of insurers, the VHI, which is non-profit, obviously would be left not able to cherry pick, and the other insurance companies could cherry pick who they decide to insure and not to insure depending on age or vulnerability. And in that sense, this is a very welcome piece of legislation because it equalises that risk. However, when we look at why this is necessary, the word surreal comes to mind, Minister, in relation to it. And just before I'll go with facts first and then go into the surreal nature of why this mechanism and this legislation is needed every year, and really the hypocrisy of government after government in relation to their commitment to a public health system while all of the time promoting the private system, albeit on a non-profit basis with the VHI, and then subsequently, because of the pressure from the EU free trade laws, they had to open up that market. That was hailed as great progress, which, if you take a limited view of it, it was, because it opened up to more insurance companies. And you may remember Bupa, I think, came in, one of the first, and they were one of the first to leave as well when they didn't get their own way in relation to risk equalisation, and they fought many court cases in relation to that, to stop that. But so I'm going to go back in a minute in the time I have to sort of give a background to this and how it is that we're praising a scheme like this, and we see what the naked market does when we look at what Bupa did and brought the government to court after court in relation to the equalisation scheme, which, if they had won, would have meant the insurance companies could have cherry-picked who they wanted. So we have, as I said, it was opened up 30 years ago. And prior to that, the VHI had a monopoly. In June of this year, we learned that 2.46 million people, almost 50% of the population, 47.6% to be precise, have health insurance. The annual cost is over 1,500 per year and so on. In 2022, the total premium income was 2.93 billion. And this point has already been mentioned by Deputy Shortall in relation to the actual money collected in premiums is tiny relative to the spend by this government and other governments in relation to providing a public health system. And yet that income and that entitlement that goes with a premium allows extraordinary leverage to consultants, indeed to patients, to a sense of entitlement, and all of that which I hope to come back to. I'm someone that has seen it from both sides in terms of having the privilege through family of having a VHI, was a member, no longer am. So, interestingly, the size of the market has grown by 3% in 2002 compared with 2021, and we now have almost 80,000, 79,553 more people with health insurance. Now, this is an extraordinary increase, even though it's relatively small, but it's an extraordinary increase at a time where this government and the last government committed to a public health system. So, and we had a cross-party agreement with Sláinte here that we would go down the road of public medicine, equal access for everybody, and that the insurance would be phased out, certainly the tax relief on it would be phased out, and that insurance then would be for when people choose to have an insurance policy to be treated in a private hospital, full stop, with no more access to the public system. And I'm sure, Minister, that you actually agree with that. And I'm sure a lot of your colleagues agree with that in Fianna Fáil. The problem is the government policies have complicated matters no end. And actually we have a surreal situation where we have a state-owned company, VHI, actively promoting private medicine. Now, surreal doesn't capture really what governments have done. And if we go back to almost 20 years ago, 2004, the ESRI, health insurance in Ireland, issues and challenges. And because of the time, I'm going to quote their conclusions. Almost half the population at that time now pay for private health insurance, one of the highest levels of coverage in the OECD. This is despite the fact that everyone has entitlement to public hospital care. Everyone has entitlement to public hospital care from the state, and hospital care is what private health insurance mostly covers. The insurance can avail of private health care, although much of the private health care is actually delivered in public hospitals. So we set up a scheme, we encourage people to go, take out membership, get a premium, so they can be treated in public hospitals, paying privately and gaining access. The resulting two-tier system is now widely regarded as problematic. This was 19 years ago, the ESRI. The two-tier system is now widely regarded as problematic from an equity perspective, but there are also serious efficiency issues to be faced because of the incentive structures embedded in this particularly close intertwining of public and private. So the incentives to have more and more private patients in a public hospital so that they gain income. The recent introduction of competition in the health insurance market in a tightly regulated setting has led to the introduction of a wider range of insurance products. So the government ostensibly were doing something good, opening up the competition, and the ESRI clearly set out that this did not address the fundamental problems of inequity. The Irish experience shows that a structure designed to take advantage of possible benefits for the public system of close interaction with private care can create perverse incentives, be inequitable in terms of access and utilisation, and undermine the public system. The political economy of reform is, however, highly problematic. Now, that's 19 years ago. I could go back a little further and further. 2001, the National Health Strategy, that stated quite openly that the public-private mix of beds in the public hospital was intentional to ensure that the two sectors could share resources, clinical knowledge, skills and technology. However, the overlap also gave rise to complex incentive patterns and concerns about equity. 2001. 1989, the Commission on Health Funding recommended the introduction, can you imagine? 1989, the introduction of a common waiting list. Can you imagine we had got to the point in this republic, which had been declared a republic in 49, announced in 48, and we have to have a commission tell us that we need a common waiting list, that we shouldn't be distinguishing between private and public patients, and that it should be prioritised on need, medical need. And so that continued and continued. And ostensibly, not ostensibly, I spent 10 years of my life on a health forum, which I've referred to many times here, as did other councillors. And I watched the systematic undermining of the public health system, while simultaneously the promotion of the private system. I remember sitting on a city council that rezoned land by majority to allow a second private hospital in Galway on the basis, the councillor said, that 20% of the beds would be reserved for public beds. Total fallacy, a total lie, total misinformation, and we talk about misinformation. No 20% were ever kept. But what we did do, Minister, was set up the National Treatment Purchase Fund. Remember that? 21 years ago. We're in usually a time for reason, isn't it? That we would have a sense of reason and realise our mistakes at 21. First established in 2002 to treat patients who had been longest on public hospital waiting lists. Remember now, we were actively promoting the private system all along while we were doing this. In 2002, 21 years ago, it had 5 million. In 2023, a total of 150 million. 150 million in 20 years, 21 years. And what's that 150 million for? So they can treat direct patients into the public system where the system has failed to treat them, but now we're going to pay under the National Treatment Purchase Fund to get them treated, or in the private hospital in Galway City, 2 of them, or any others, Kilkenny, I know people who've been down there, the north and abroad. What kind of a farcical, surreal system is this? And in the meantime, while we're doing that, and just to bring that home to you, I know somebody who'll remain nameless, I won't say if it's a man or a woman, who came into my office in relation to a hip. And I don't like anecdotes ever, but it goes to the kernel or the heart of what we're talking about here. On a waiting list on the public system, and the wonderful consultant who both public and private said, I'll do it privately for 12,000. And so that person went off and got a loan for 12,000 for a hip replacement and got it done. Of course, it's in limbo now, but we don't have limbo anymore because he goes back to the private system, he has to pay. On the list on the public system, he's gone. 12,000. The same consultant who has stood over a long list building up in the public system, and I don't hear their voices raised in outrage. And then on top of that, the background is that we have 588,813 on an outpatient nationwide, of whom 81,356 are children, and so on. These figures have been given here repeatedly, but let me just be parochial for a minute in relation to the orthopaedics in Galway. There are 6,694 adults on the orthopaedics outpatient list. 1,230 adults have been waiting 18 months or more. Remember now, we have a thriving private system where if you've 12,000, you can get the job done. And in the meantime, we have 1,230 adults waiting 18 months or more. There are 622 on the UHG orthopaedics outpatient list. 261 have been waiting 18 months or more. On the inpatient list in Galway, 118 adults are waiting 18 months or more. On the trolley watch, Tuesday, the 21st of November 2023, 562 patients on trolleys nationwide, of whom 428 were in emergency departments and 134 closeted away on wards. 39 patients on trolleys in Galway, 31 in the ED, which is not fit for purpose and now has a temporary one, and 8 wards elsewhere. And into this then, we bring a recruitment freeze, and we announce a recruitment freeze that's only to do with management, and we point out it's not to do with consultants, nurses or midwives. And then a little bit more comes out from the head of the HSE, who I admire as an honest, straight person. I've seen him on the Health Forum, absolutely blunt and straight. And he tells us, really, that's not exactly what the recruitment is, it's more than that. And in the meantime, then we get letters from a clinical psychologist and a speech therapist telling us that this recruitment ban will affect them. And even more bizarre, the speech therapist tells us that she's working through an agency which is costing the health executive more money. I won't use up my time to read it out, but I'm sure we all got these letters spelling out clearly what is happening in terms of a recruitment. On top of that, you see, I was told there was no money when I was on the Health Forum. There had to be cutbacks. Refurbishment of beds, people couldn't be employed. Then since I came to the Dáil, I'm being told money is not a problem. Money is not a problem, it's just the staff aren't available. As I stand here, I know there are 5 empty beds in the nursing home in Carrow. Cúig labhairt tá follow bhí grílár na Gaeltachta, mar níl siad an fuirden all. They can't get staff. And now we have a staff recruitment. Honestly, I've used the word surreal and I don't use it easily, but I really have a difficulty fathoming what's going on here in relation to a freezing on staff. We have delayed discharges in the hospital in Galway, some for years, because there are no nursing home beds. We have privatised the whole nursing home section. It's less, I think it's 17% that are public nursing home beds now. Can you imagine that, 17%? And on any given week, when you open the paper, you see another private company in trouble. Your colleague, Minister Butler, has acknowledged, and it's been in the paper, about the company Paris, who own a company in Galway as well. Huge problems in relation to governance, fire, and so on. And who's going to pick up the pieces? The public purse. That's what's happened repeatedly. It's happened in Galway, Árachais, where they had to send in public nurses to operate the private nursing home. And most of them now are huge, big companies. And then we go to primary care. As of the end of 2022, there were 160 primary care centres open nationwide. And what is happening in relation to those? The vast majority are owned by companies. Indeed, one of the companies' director was the former head of the health executive, who saw the gaps, who saw the opportunities. And so the companies, private companies, are now providing the primary care centres. And we will lease it back. Does that make sense? Does it make sense that we would, while we're going down ostensibly the route of Sláinte care and public medicine, at the same time we're promoting private insurance, and then along with that in the primary care, which is supposed to be the new, to take the pressure off the hospitals, we've privatised it almost completely. Would you have any idea, Minister, what analysis has been done, what risk assessment has been done of the move from this government and the previous government to provide health centres that are all owned by for-profit companies? What happens when they get into trouble? What happens when they fold? What do we do then? And finally, just in relation to Galway, there was an options appraisal in Galway back in 19 in relation to what was the future for Galway. We have the regional and the Merlin and 2 private. And I foolishly relaxed when I saw the options appraisal going for a brand new hospital in Merlin Park, built for purpose. Nothing happened. And when I asked lately, I found out there was a second options appraisal which was carried out a few years after that. And suddenly they said, we'll keep building up the congested site and we'll put up a few little places in Merlin. So we'll have a new elective hospital in Merlin and we'll have a new surgical hub. But the original plan for a brand new hospital went, I was told, by the clinical director because the government failed to act or give them the thumbs up for that options appraisal. So we're now down the road of a different options appraisal that's leading us to build on the congested site, build in a jigsaw manner without an overall picture for Merlin Park Hospital, and constant delays. And so if we look, and I'll finish on this, the accident and emergency, the then Minister for Health, the current Taoiseach, said a new building was the only solution to the problems in UHG. 2015, Endokendi, the ED was not fit for purpose. This 2016 programme for government committed to looking at it, and so on and so on. The interim ED, so we get an interim ED, I think was 15 or 16 million, and that opened in October 22. I'll finish up within my time, Chair, and it's hard not to despair. It's hard not to, how can you not see that a public health system with equal access for everyone is the most fundamental requirement of a republic, as is housing that gives shelter, so that people can then participate in society on an ongoing basis. The kernel is to have shelter and access to public health. Instead of that, We have privatised every way we can, from the diagnosis to allowing doctors have private a building in Merlin Park for diagnosis. And if we go to, I'll finish on osteoporosis, fantastic public service with not enough equipment, and everybody being directed out to the private clinic for osteoporosis scans.